So this is a bit of a change in gears. As we think about the aging of the population, let me see if I can move forward. How do I progress? Let me see. How about just this? Very good. Well, first, just disclosures. Thank you for your support as taxpayers. I do want to start out with a case, which is not uncommon for those of us who work in the community mental health sphere with aging people with mental illness. And this is actually an individual who's in a study that I'll tell you about soon. That is an individual who's in subsidized housing in Boston. He has many medical diagnoses along with his primary diagnosis of schizophrenia. He's in and out of the hospital frequently. And he has a goal in life, which is actually to live beyond the age of 52, which actually is the median age for survival now for people with serious mental illness, and actually to do some of the things that are described there around his own personal aspirations. And this is perhaps familiar to you, but this continues to be a startling slide to me when I think about it, which is that for many of us, we are looking at the age of 75 is the new 65, or whatever the case may be. But here we're looking at people with major mental illness as having an attenuated life expectancy of anywhere from 25 to 30 years. And that may vary all the way down to 11 years as a life expectancy, but it is startling. And the major cause of early mortality for people with mental illness as they get older is not suicide, but actually is heart disease and cancer. So what we're looking at is a health disparity population, which is roughly 3 to 5% of the population. We're looking at a life expectancy which is attenuated, and we're looking at the need to think about how people with major mental illness as they get older manage their increasing numbers of health conditions, and there are excess numbers of health problems that occur for people with mental illness. So a number of years ago, we thought about this, and we thought about the fact that we were focusing in the field on self-management of psychiatric illness, that there was this thing called IMR, of Illness Management Recovery, that we developed at Dartmouth, where I used to work. And it was all about managing your psychiatric symptoms, managing depression, managing early symptoms of psychiatric relapse, on and on. But as a geriatric psychiatrist, it became clear to me that the things that people in middle age and late life were really encountering with mental illness was not so much going in and out of psychiatric hospitals, but actually going in and out of medical hospitals and actually having excess morbidity and mortality due to the healthcare problems that occurred. So we developed an integrated model of self-management that had to do with managing your psychiatric and medical symptoms, called Integrated Illness Management Recovery. And in that early on, we codified it, and we developed and did an initial small study. Everybody in it had major mental illness and had either diabetes, COPD, CHF, coronary vascular disease, hypertension, or arthritis. And the focus was on helping individuals to self-manage, both the psychiatric and medical illnesses. And just a number of findings. We had people who were in this program had greater knowledge of symptoms, greater capacity to manage their symptoms, decrease symptoms affecting functioning, increased participation in healthcare encounter, coming in, working more proactively with their primary care doc, and then decrease hospitalizations. So that was good, but here's the problem. This really required lots and lots of individual face-to-face training between a coach and the individual with major mental illness to get them up to speed around how to manage their psychiatric and medical illness. We also tried groups. That worked pretty well. But the scaling issue was just huge. How do you think about, and we just heard a wonderful presentation around implementation. How do you kind of move things out when you find something that works? And self-management works, even for people who are older. And what we thought about was what we can do to bring this into the home setting and to make it work. So the first generation of this attempt at thinking about integrated illness management was an automated remote telemedicine device where we partnered with a with a company that had this thing called Health Buddy, and actually developed libraries that were psychiatric to match the libraries that were medical, and conducted an initial study looking at individuals, again, with serious mental illness and diabetes and COPD and other disorders. And the way that this worked as an automated telehealth device was that every day the individual with major mental illness would check in on this little box next to their phone on a very simple set of buttons that they would push, and would actually respond to different inquiries around their medical and psychiatric illnesses. And then also we had Bluetooth capability with respect to blood pressure, glucose acquisition, fasting glucose, a number of things that were remote medical devices that we could hook up to this. And then the whole idea was that this would help people around not only giving them advice, which it did through libraries of self-management that were individually tailored for that person's set of illnesses. People with schizophrenia and diabetes got something different than people with bipolar disorder and congestive heart failure. And remotely, our nurse, who I supervised, would look at this panel and would see people drifting into the red zone or yellow zone or green zone, don't worry about it. And the great thing about that was, for someone who was a medical director of mental health system for years, sending out case managers to visit someone 2 or 3 times a week who's frail was just expensive, and also most of the people didn't need it. So this actually targeted and highlighted in an automated, algorithmically driven way, the people that were at risk and the people who were rising risk. And then what the individual could do, the nurse, would text message, call, or intervene for those people at risk. Now, it just so happened in this small study, many of the individuals who were in this study had diabetes. And what we found early on, that about 2/3 of the sample had diabetes, just happened to. This was a pragmatic trial. In the subgroup with diabetes, about 63%, or 2/3, were out of control when we started. And within 6 months, you can see here that 2/3 were nicely in control, just in 6 months. And this was really associated with significant response in terms of also hospitalization and emergency visits that dropped and plummeted during this trial. And again, this had to do with this capability of both self-management on one's own, and the type of teaching and instruction that happened, but also the monitoring, the capability to do real-time monitoring remotely and stratify risk and target those individuals who are most in need. So this was good, this was promising. It just so happened that we decided to put in a second large study, an R01 study in Boston, and started down that path, and within 3 months, and this is a cautionary note to all of you who are academicians working with industry, in 3 months the VA decided not to renew the contract with the company that was the original platform, and they shut down the device that we were using. At least that company decided not to continue to have that device. So we quickly had to find another vendor, completely tee up the library again, which is, I had to talk to my project officer at NIH and said, well, this has never happened before, but we're going to completely reboot this study right out of the gate. And this is the dynamic changes of industry and partnerships that sometimes go well and sometimes don't. But we found another partner. And that was actually, as it turned out, a positive development in our journey, in the sense that we actually moved from that box that you saw to a tablet. We developed a somewhat new library and modified it, and I think improved it actually. We focused on a number of things: medication adherence, symptom monitoring, education about illness, lifestyle, and again, once again, matched the libraries to the individuals. And again, this is relatively rudimentary, and I think as time goes on, obviously, AI and a number of different machine learning strategies would actually help this sort of technology. But this was, again, a prototype early on. And what we found was that we put together this content in terms of these specific medical conditions and psychiatric conditions, and developed a dashboard, or adapted a dashboard, and you can see here the fact that we could both find people that were at risk and then monitor among the high risk those individuals. And in this instance, instead of a nurse, we actually had a care manager who was supervised by a nurse, thinking about task shifting and less expensive approaches, who would chronicle specific individuals who are at risk, and then indicate the action that they would take and keep a record of that. So we, over time, could actually track how people are doing over time in terms of the interventions and the ways in which they experienced the care. So this actually brought up an interesting question once we kind of developed this. Which works best for individuals who don't have dementia but have cognitive difficulties? People with schizophrenia, bipolar disorder, chronic depression who live in the community as they age. They have different abilities to absorb new information. They have information processing difficulties. They have a host of challenges, multiple social determinants of health, low socioeconomic status, on and on and on. What works best? Does the automated telehealth work? Or is it the case that the human individual who actually is the care manager going out and touching that person relatively regularly actually is preferred? So we decided to do a comparative effectiveness trial to look at this kind of, I guess you could say, man, woman versus machine, I guess, a comparison, you might say, looking at automated health or health coaching and self-management training, and proposed this as a comparative effectiveness implementation trial, which we are just finishing in November. So I'll share with you a couple of early findings, but we will have data, I think, actually it's November's next month. We'll have data at the end of November, early December on everybody. But what we have here is, as you can see, a similar sort of sample. We're talking about middle-aged individuals and a good distribution by gender and by race and ethnicity. And you can see that many people have major mental illness and mood disorder and have a number of psychiatric conditions. Among the early baseline things that actually was kind of remarkable and interesting to us as we started to look at this automated capacity to understand people's unmet needs early on was an issue of differences by race and ethnicity. This was a work that was done with a medical student that I work with who was interested in this topic. And what we found really, I think, of significant interest was that not only was there significant or substantial undiagnosed hypertension in this sample. Again, we were able to measure hypertension through these remote Bluetooth devices. But it also varied significantly by race and ethnicity. And you can see Hispanics here having a much significantly higher rate of undiagnosed hypertension by race. And then if we also looked at other disorders, because we could also look at individuals with respect to hemoglobin A1C and looking at also their fasting glucose, what we found was that there was also significant differences with respect to race and ethnicity relative to diabetes control. So overall, this is, I mean, regardless of race and ethnicity, we're looking at the majority of people with major mental illness have poorly controlled diabetes. So that's not good right out of the gate. And as I told you that earlier slide, we found that in an early study. So we have people that are out in the community with high rates of obesity, smoking, diabetes, and so it's no wonder that individuals with mental illness, psychiatric illness, are dying early because of very poorly controlled illness. And these individuals tend to have primary care docs. And so I think that this issue of how we can remotely monitor and get better on top of these issues makes sense. I can tell you that in talking to a primary care physician early on in one of the prior studies, he said to me, I kept on thinking that the glucose that this person was coming in with was in the 400s was because she kept on coming in and having donuts before she came in for my tests. And now that I see the stream of data, she's always running 400s. I didn't believe them. And so this issue of kind of real-time capability makes a big difference. So we're, again, completing that trial and should have results soon. But finally, you know, what might be other generations of thinking about how to help people who age with mental illness in the community? And one of the things that we've been interested in, a postdoc of mine, former postdoc who's now an assistant professor, will be presenting tomorrow, Karen Fortuna, was thinking about how peers and mobile technology can actually contribute to illness self-management. And so in this instance, what we've done is taken this program that we've developed, this integrated illness self-management program, and loaded it onto smartphone applications and having remote monitoring by tablet, and being able to look at how these individuals might benefit not just from the electronic capability of remote monitoring and capabilities, but also the power of peer support. Having individuals with lived experience with that individual, helping to coach that individual, and that's what we're testing right now. So that takes out of the frame this idea that it's either humans or machine, but actually blending humans who actually people identify with as supports and being guided in self-management support. We did a very small pilot of this, pilot study. And actually, that's the remote tablet, that remote capability of monitoring outcomes that we have also on a laptop. And Dr. Fortuna developed this smartphone app based on all the work we'd done previously, and did a small pilot study that was published in the American Journal of Geriatric Psychiatry. And here, the mean age is 68. These are actually legitimately older people with mental illness. And although it's an N of 8, you can see that the trends are all in the right direction around medical self-management and even statistically significant psychiatric self-management that actually is really quite promising and really interesting. And so the question of whether or not, again, peers, individuals who actually are present in the community and can, in fact, scale this intervention along with electronic capability remotely, put together, maybe we can do population-based management that we couldn't do before using this sort of technology around comorbid and medical and mental health conditions. So what we decided to do was, yet again, another comparative effectiveness study. In this instance, we applied to PCORI, the Patient-Centered Outcomes Research Institute. And what we decided to do there was actually to ask a public health question. And the public health question we found was that when we looked around the country and we were thinking about what are all the mental health centers doing or the mental health organizations doing around illness self-management for people with mental illness. And what we found in all of these funded pilots around medical homes was that almost everybody was using this version, this thing called chronic disease self-management, CDSMP, the Stanford model of self-management, this peer-led 12-session kind of guidebook around taking care of your medical illnesses and living a life with chronic conditions. Even though there was no real clear evidence that this actually works for people with SMI, maybe one observational trial, we said, you know, this is a problem. It's the generic, it's good for many people. This has had great traction in older adults and in senior centers across the country. We actually had it in the Center on Aging where I worked previously. But being used in large order because it's scalable and it's practical and doable, but limited in evidence. So what we decided to do was to propose a head-to-head and to do this comparative effectiveness trial, which we're now starting recruitment as we speak right now over the past month, of 600 adults with serious mental illness and comorbid mental health condition, comorbid chronic health conditions. And here what we're doing is we're taking this self-management training and peer support smartphone, and we're comparing it to what everyone's using. Now, you could say that's an unfair comparison because one is not as targeted as the other. That's the whole point. One is being used and disseminated largely, CDSMP. This other approach, we haven't really had the traction that we'd like, and we hope we will with the studies that we're doing. But we believe that this hopefully will provide a tailored approach to combining peers, combining self-management training and smartphone peer support to help people with major mental illness who have all of these comorbid health conditions not die at the age of 52, but live long and fruitful lives. Thank you.